Good morning again. I have got this TOG article which is titled as Perioperative Management of Women on Oral Anticoagulants and Antiplatelet Agents Undergoing Gynecological Procedures. I've summarized this to help with your revision for MRCOG exams. I hope you'll find this video useful and give this video a thumbs up and subscribe to my channel if you haven't already, and also share it with your friends and colleagues. So, direct oral anticoagulant, shortened to DOAC, does not require INR monitoring like the warfarin, for example. Commonly used direct oral anticoagulants are apixaban, rivaroxaban, dabigatran, and edoxaban. So patients with high thrombotic risk who should be considered for bridging with treatment dose heparin when they stop warfarin include patients who've had venous thromboembolism within the previous 3 months, very high risk patients for venous thromboembolism who have a target INR of 3.5, patients who have AF, so patients who've had a stroke or transient ischemic attack, TIA, in the last 3 months, patients who've had a previous stroke or TIA and have 3 or more of the following risk factors: congestive cardiac failure, hypertension, over 140 over 90, age over 75 years, diabetes mellitus. Mechanical heart valve, so patients with mechanical heart valve other than those with a bileaflet aortic valve, and no other risk factors. So this is the class of patients that are considered high risk and should be started on a bridging plan with treatment dose of low molecular weight heparin when they stop warfarin. So for elective gynecological surgery, warfarin should be stopped 5 days before surgery. If there's high risk of VTE, then the patients require bridging low molecular weight heparin. Last dose should be given 24 hours pre-op, as we talked about it in the last slide. Post-op bridging with full dose anticoagulation should be considered. At least 48 hours after procedure, there's a high bleeding risk. Prophylaxis with low molecular weight heparin should be considered in the interim. Restart normal maintenance dose of warfarin in the evening of surgery or next day. Because the onset of action is quite slow and takes more than 24 hours, it should be restarted as soon as its hemostasis is achieved. Bridging therapy with low molecular weight heparin continues until INR is in therapeutic range. If there is low thromboembolic risk, they do not require bridging therapy. So direct oral anticoagulants, depending on the risk of bleeding, the plan should be individualized by the operating surgeon. Timing of discontinuing depends on the bleeding risk and the renal function of the patient. The advice for apixaban, rivaroxaban, and edoxaban is identical, and dabigatran is different. We'll go into specific advice from the table in a few minutes. So women taking antiplatelet agents, so things like aspirin and clopidogrel, they're basically adenosine diphosphate ADP receptor antagonists. So some patients will just be on aspirin and others will be on dual therapy, so both on aspirin and clopidogrel, especially if they have been recommended following ischemic cerebrovascular disease. So patients on aspirin can carry on can continue safely for gynecological procedures. Dual therapy patients, so patients on both aspirin and clopidogrel and who have had a recent acute coronary syndrome or coronary artery stenting, then surgery should be postponed for at least 6 months. Local hemostatic agents, so in things like minor procedures like LETs, for example, Monsell solution can be used, which is ferric subsulfate, or cauterization with silver nitrate. And if this doesn't control the bleeding, then vaginal packing can be considered. In procedures such as excision of Bartholin's abscess, and if hemostasis cannot be achieved, then things like electrocautery or oxidized cellulose can be used as local hemostatic agents. So, medical procedures and their associated bleeding risk. So, this box classifies your common gynecological procedures into no bleeding risk, minor bleeding risk, and major bleeding risk. So, no bleeding risk is your pelvic examinations, your smear tests, and your genital swabs. Minor bleeding risk is your cervical biopsy, diagnostic hysteroscopy, and resection of polyp, labial and Bartholin's abscess, large loop excision of transformation zone, myosure polypectomy, novosure ablation, pipil biopsy, transcervical resection of endometrium, and vulval biopsy. Major bleeding risk is all-day case and inpatient surgeries. So for emergency gynecological surgery for warfarin, the British Society for Haematology recommends that if surgery can wait 6 to 8 hours, then 5 milligrams of intravenous phytominadione can be given to achieve a desired INR and restore coagulation factors. If surgery cannot be delayed, then 25 to 50 units per kilogram 4-factor prothrombin complex concentrate can be given and INR checked. Direct oral anticoagulants delay surgery to allow plasma levels of drug to fall. The concentration of drug can be estimated from the dose and the half-life of the drug, time of the last dose, and the woman's renal function. If it's not possible to delay surgery, tranexamic acid can be given to reduce bleeding, and drugs that impair hemostasis, such as NSAIDs, should be avoided. Idarucizumab can be used to reverse effects of dabigatran before emergency procedures with a high bleeding risk. A normal thrombin time can indicate minimal circulating levels of dabigatran. So antiplatelet agents, no specific reversal agents for clopidogrel. Irreversible platelet inhibition lasts for lifespan of platelets at least 7 to 9 days. For women on antiplatelet agents requiring emergency procedures with high risk of bleeding, the British Society of Haematology recommends considering use of tranexamic acid. If there is still excessive bleeding, an infusion of 2 poles of donor platelets can be considered. Neuraxial anesthesia, so intrathecal or epidural anesthesia, is a high risk intervention. Rare complications like neuraxial hematomas can form. Spinal and epidural anesthesia can be undertaken without stopping at non-steroidal inflammatory drugs or aspirin. Patients on ATP receptor antagonists discontinue the medication 7 days before the procedure. The timing for neuraxial anesthesia similar to those when planning for high bleeding risk. Okay, so extremely important table. Now this is where the table goes through the mechanism of action for every drug, the half-life, the elimination, when should it be stopped and when should it be restarted for all the agents that you need to know. So over the next 2 slides, we'll cover all the anticoagulant agents that you will need to know for your exam. So warfarin, so it inhibits vitamin K. Reductase, basically preventing vitamin K required activation of clotting factors 2, 7, 9, and 10, approximately 36 hours of half-life. Elimination is 92%. When should it be stopped? So low bleeding risk, 5 days prior to the elective surgery with INR check ideally the day before surgery. High bleeding risk, 5 days prior to elective surgery with INR check ideally the day before surgery. Bridging with treatment dose low molecular weight heparin should be considered in those with high risk of VTE. When should it be restarted? So for low bleeding risk, start warfarin when adequate hemostasis is achieved, approximately 12 to 24 hours after completion of surgery. Low molecular weight heparin can be restarted 24 hours after surgery until INR in therapeutic range. High bleeding risk, low molecular weight heparin should not be given until 48 hours after surgery. Restart warfarin when bleeding risk is minimized. Low molecular weight heparin should be continued until INR is in therapeutic range. Mechanical thromboprophylaxis should be considered in all cases until INR is in therapeutic range. Apixaban is a factor Xa inhibitor. The half-life is 8 hours. 27% is renal elimination, and 73% is liver. Low bleeding risk, creatinine clearance of over or equal to 30, stop 24 hours prior. If creatinine clearance is less than 30, then stop 48 hours prior. For low bleeding risk, recommends 6 to 12 hours post procedure. For rivaroxaban, factor Xa inhibitor, half-life is 9 hours, 33% is unchanged via the kidney, 66% is metabolized in the liver and then eliminated via the kidney or the colon. For high, it's the same for apixaban and rivaroxaban. So for low bleeding risk, if the creatinine clearance is greater than 30, then stop 24 hours prior. If creatinine clearance is less than 30, then stop 48 hours prior. For high bleeding risk, both for apixaban and rivaroxaban, creatinine clearance greater than 30, stop 48 hours prior. Creatinine clearance less than 30, stop 72 hours prior. For high bleeding risk for both, wait 48 hours before introducing at the full dose. If high risk VTE, consider prophylactic dose of anticoagulation before restarting at full therapeutic dose. For the edoxaban, it's also a factor Xa inhibitor, and half-life is 10 to 14 hours. 50% is renally excreted, and in terms of when to stop and start, it's exactly the same as your apixaban and your rivaroxaban. For your dabigatran, it's a factor 11A inhibitor, 13 to 18 hours depending on renal function. 80% is renally excreted and 20% in bile. Low bleeding risk, if creatinine clearance is greater than 80, then stop 24 hours prior. If creatinine clearance is greater than 50 to less than 80, stop 48 hours prior. If creatinine clearance is over 30 to less than 50, stop 72 hours prior and recommence 6 to 12 hours post procedure. For high bleeding risk, if creatinine clearance is greater than 80, stop 48 hours prior. Creatinine clearance of over 50 to less than 80, stop 72 hours prior. If creatinine clearance is over 30 to less than 50, stop 96 hours prior. It's high bleeding risk, wait 48 hours before reintroducing at the full dose. If high risk VTE risk, you can consider prophylactic dose of anticoagulation before restarting at full therapeutic dose. For aspirin, which is a COX inhibitor, the half-life is 15 to 30 minutes. Continue. You can carry on using it, and again, when should it be restarted? Again, you just carry on. Clopidogrel is a P2Y12 inhibitor, 8 hours of half-life, low bleeding risk. In patients with a recent coronary syndrome or coronary artery stent on dual antiplatelet therapy, it's important to assess the need of performing the surgery, and consultation with hematologist should be considered before proceeding. Restart when hemostasis is achieved 12 to 24 hours post procedure. For high bleeding risk in patients with recent coronary syndrome or coronary artery stent on dual antiplatelet therapy, if possible, postpone surgery. If not possible, stop medication 7 days before and continue with aspirin following liaison with hematologist. And this is true for clopidogrel, prasugrel, and ticagrelor as well. So ticagrelor is a P2Y12 and P2Y1 receptor inhibitor. The half-life is 7 hours, but the stopping and restarting instructions are exactly similar to clopidogrel. Well, I hope you found this video useful, and if you do, please don't forget to give this video a thumbs up and subscribe to my channel if you haven't already, and also leave a comment if there's any particular talks that you'd like me to summarize for your upcoming exams, and I wish you all the best for your revision.